Professor Cowie, thank you very much for sharing your time with us. I'm just going to start right away.
Pleasure.
There's a big hype at the moment surrounding SGLT2 inhibitors. How did the diabetes drug become a heart failure drug?
Well, it's a very good question because, as you say, SGLT2 inhibitors look like the new wonder drugs for heart failure, for cardiovascular risk reduction, for renal disease. How did we get there? And I think they were initially developed to improve the control of type 2 diabetes. And then the FDA said, let's do safety studies to make sure they're safe. And boy, are they safe. In fact, they reduce events really quite dramatically and across the board and very consistently in all the trials. So the SGLT2 inhibitors, I think, are going to become part of the mainstay of cardiovascular risk reduction for many patients.
And there are currently a few studies on the way that are looking on the therapeutic potential of those inhibitors in non-diabetic patients. What are your expectations from those?
We've actually had the readout of 2 studies that have looked at patients with diabetes and without diabetes, and that's in heart failure. So we had DAPA-HF, and both of those trials had about half and half diabetes and not diabetes, and the outcome was exactly the same for those 2 groups of patients. So I don't think it's working just by improving glucose control. It has multiple other effects in the body which seem to be helpful. And the other thing that's very interesting is in kidney disease. And DAPA-CKD just read out at the ESC this weekend, and that also had patients with diabetes and without diabetes, but they all had renal disease and didn't modify the effect, the benefit. And just to make it clear for viewers that in DAPA heart failure and DAPA-CKD, there was an all-cause mortality reduction for those patients. So this is really important therapeutic breakthrough.
This has been a hard year for everyone, but especially for heart patients. Have there been any particular learnings from the COVID-19 crisis for the field of cardiology?
Yes, I think COVID has disrupted everybody's lives, both patients and also physicians. We've learned how to do remote consultation. It's really accelerated digital technology into clinical practice. And of course, that has its issues. It's not as good as face-to-face, but I think it's been reassuring for patients to be able at least to see their doctor or hear their doctor and get some support during that period. Now we're in an interesting phase. COVID is not over. We still don't have a vaccine. We're trying to reopen services. But how do we do that? How do we blend remote technologies, remote monitoring with face-to-face consultation? And what does it feel like as a patient to have that? So lots of pros, lots of cons, but I think we're all finding our way with that. It's finding some solutions to a difficult problem.
Professor Cowie, thank you very much for insights and for your time. And
pleasure.
All the best of luck for the rest of the year.
Thank you so much. Bye-bye.
Thank you. Bye.
Bye.